Okay, perfect. All right. So I'm a pulmonary critical care physician. I'm at Cooper Hospital. I've had the pleasure of coming to your beautiful country a few years ago, and we really enjoyed it. It was a wonderful experience. So hopefully I'll be able to come and visit with you, all of you soon, possibly in the next couple of years when everybody comes over. So as you said, I'm going to be talking about the topic of, oops, what's happening here? It's drawing on my screen now. All right, that's okay. All right. See if this will advance now. Okay. So we are going to talk on the topic of respiratory approach to respiratory distress in a patient who is pregnant. So the first things we're going to talk about is a little bit of physiology as to what the normal physiology would be in somebody who is who's pregnant, so that we can review that part before we go to the pathology. Okay. So in this, the main things we're going to talk about is that there's significant amount of airway edema in this patient. So this is part of the increase in the blood volume with pregnancy. There is a greater resistance to flow. So if you're trying to use a bag valve ventilation, it becomes more difficult because of the airway edema. There's also greater risk of airway obstruction with sedation. So once you give sedation, if the patient is pregnant, that is going to be difficult. So this is kind of a handy way to remember describing the range of changes which takes place, mainly characterized by an increase in the volume of the airway soft tissue. Some of this is fat, some of this is edema, and all of it gets in the way of the laryngoscopy. So there is also a structural properties of the chest wall and lung volumes if we go through the different functions. So the structural properties of the chest wall and lung volumes, there's anatomic changes. The diaphragm is pushed up by about 4 centimeters. Weirdly, not all of this is due to the effect of the gravid uterus pushing up the abdominal contents. There are some hormone-induced laxity of the rib ligaments, which begin well before the uterus becomes large enough to kind of push the abdominal contents into the chest cavity. This, however, does not decrease the mechanical effectiveness of the diaphragm. And if anything, it works more efficiently during pregnancy with an increase in the diaphragmatic excursion by about 2 centimeters. The diameter of the lower rib cage increases. There's an upward shift of the lower costal, the bucket handle, kind of the pivot that you may remember when you were studying physiology, and the angle of the junction of the ribs and the xiphoid increases from a normal angle of about 70 degrees, 68.5 to be precise, at the beginning of pregnancy to about 100 angle at term. So the chest cavity itself becomes shorter, but the other dimensions also increase to maintain a relatively constant total lung capacity. So this is a cartoon that kind of gives you an idea of what that looks like in a gravid uterus. So some of the respiratory physiology itself, there are some changes that happen as well. The tidal volume increased by about 30 to 50%. The increased diaphragmatic excursion changes the tidal volume, let's say about 500 ml in the first trimester to about 700 ml in the third trimester. The respiratory rate increases from about 15 to 17%. 15 to 17%. The minute ventilation, minute volume increases by about 20 to 50%. This seems to be driven by progesterone, as it will be. We'll be discussing that a little bit later. The FEV1, FEC remains essentially the same. There was a paper back in 1979 that reported the results of about 30 pregnant women who, in spite of changes in their lung volumes, maintained an essentially unchanged FEV1 FEC ratio. It varied anywhere between 84% postpartum to about 81% at term. So as you can see in this cartoon here, it kind of depicts the differences as in the blue column, what it looks like in pregnancy, and in the white column, what it is at baseline. So the structural properties moving on. Continuing with that, there's also changes to the mechanical properties of the respiratory system. So the compliance, there is changes in the lung compliance itself decreases, but the chest wall compliance decreases because of the edema, but the lung compliance itself does not change. As one might imagine, the workload of the ventilator turbine is somewhat increased by increased weight of the chest wall, right? So as the chest wall becomes more edematous, and so there's kind of the breast becomes more turgid as well. So all of that causes the increasing in the chest wall compliance. The changes in the rib wall configuration and the upward incursion of the diaphragm also play a role as the normal bucket handle mechanisms becomes disturbed. So lastly, the gravid uterus provides kind of a counter pressure on inspiration in a kind of a manner similar to a distended abdomen of an abdominal, almost like abdominal compartment syndrome. So because of that increase in pressure, the respiratory resistance changes. Initially, it increases in early pregnancy, but as the hormones become thicker, there's more and more hormones, the tracheobronchial tree, the smooth muscles tend to relax, and the resistance decreases. This was described in a paper I have referred as well in the effect of increasing the anatomical dead space itself. So some of the other changes that happen is the change in the blood gas, the PCO2 decreases, and the PaO2 increases in pregnancy. The key feature of the gas exchange in pregnancy is the increased metabolic rate of the combined mother fetus, with resulting in increase in the total oxygen consumption and CO2 production. This part of the equation makes sense because when the consumption when the O2 consumption and the CO2 production changes, it kind of goes together. So then now what you do is now you expect the mother to develop a kind of a persistent hypoxia and a mild respiratory acidosis, which would lead to a slight increase in the respiratory rate and a raised serum bicarbonate. So this is so what we see in this case is you see that the expectant mothers, they blow off the vast amounts of the CO2, and it actually generates a mild respiratory alkalosis with complete renal compensation and a normal pH. In fact, in a perfect model, if an isolated, there's more of a sustained respiratory alkalosis. So this kind of this is an unexpected development as a result of progesterone. So what progesterone does is it kind of infiltrates the medullary respiratory control centers and adjusts the homeostatic set point of the carbon dioxide. So the role of, so what is the role of all of this? So the physiological phenomenon is that it preserves of the maternal arterial oxygen during high, it kind of lives in this sense of a high altitude pregnancy. So if I may say that, so there shouldn't be any disadvantage. However, early studies of maternal hyperventilation, the placenta blood flow actually decreases in proportion to decrease in carbon dioxide. So the dysregulated cerebral vessels of a person with almost like somebody who has had cerebral injury. So the immature fetal cerebral vessels also constrict. Not only that, but the maternal pH is closely shared by the fetus. So respiratory alkalosis would result in the increased affinity of the maternal hemoglobin for oxygen, decreasing its availability to the fetus. And the fetal oxyhemoglobin, the hemoglobin oxygen affinity would also increase, decreasing in its availability to the fetal tissues. So in short, it all seems very counterproductive, right? But it's also the most of the data collected by many of the review articles that are available. So what they have done is from healthy mothers who were compelled to hyperventilate by experimentals. So obviously normal pregnant hypocapnia has little effect on the fetal cerebral vessels, and it does not have any adverse effects on the maternal fetal oxygen transport. So the basic physics, if you remember the Dalton's law, if there is less carbon dioxide in the alveolus, there's more room for oxygen. Therefore, maternal arterial oxygen increases, and then similarly, there's slight decreased maternal PCO2, creating a gradient for the carbon dioxide removal from the uterus, facilitating its movement across the placenta. So it is a very, very complicated but very beautiful way of how our bodies kind of works in conjunction. So this basically leads to it produces higher levels of 2,3-DPG during pregnancy, and then it by resulting in a decrease in the affinity of maternal hemoglobin for oxygen. So when there is a delivery of oxygen to the fetus, especially in low oxygen environments, the placental vessels, the maternal bloodstream, this 2,3-DPG accumulation would produce a right shift of oxyhemoglobin dissociation curve, which I'll show you in just a little bit. So if there is no alkalosis, but the borderline alkalinic pH of the late-term gravid uterus, which basically lives around a pH of 7.4 to 7.46 to 47, it pushes the curve to the opposite direction and to the next effect, competing influences in the actual P50 value. So in summary, what it's doing is over the course of the pregnancy, you expect to develop a progressively lower carbon dioxide and a progressively higher oxygen. In spite of this, because several of the competing influences on the affinity of the maternal hemoglobin, the effectiveness of the maternal oxygen transport is not affected. So that I am going to show you in this. So as you see, I don't seem to be able to, I don't know if I can pull the, try to, I don't know if you can see my mouse. So here what you see is the P50, how this oxygen dissociation curve in a pregnant adult moves to the right. So helping with that dissociation. So this is a cartoon basically showing all of the physiology that happens that affects the pregnancy. So I'm not going to go over this again because we need to move on. But if you have any questions later on, we can come back to this. So there's also some changes that we see in the maternal blood gas as it alters during the intrapartum period. So this, the stage of labor, so as you can see in early, there's the acid base looks more respiratory alkalosis. In the end of the first stage of pregnancy, now you're developing, now we are developing a mild metabolic acidosis compensated by a respiratory alkalosis. And then there is a mild respiratory acidosis during the bearing down process. And then at the second stage during delivery, now develop a metabolic acidosis uncompensated by respiratory alkalosis. This again is going through the changes. So, you know, we don't have to go through all of this, but I just wanted to show you how this all changes in this first column of a person who's not pregnant, and in the first trimester, how the compliance, the resistance, such changes, and you see the biggest changes in the FRC. So, and then the PCO2, as you see, going down from a normal, in a non-pregnant state, about 37 to 26 to 30. So here's where you, you know, say you have a patient that is in respiratory distress and you get arterial blood gas, and you see that the PCO2 is 40 and they are in their second trimester, something is wrong, and something may be really wrong, because now they're developing a relative, not only the metabolic acidosis that is ongoing as a result of compensation over time that has occurred, but now developing a respiratory acidosis. So what are the causes of acute respiratory failure in an obstetric patient? So what you see is that we'll discuss these different types. So there are types that are specific for pregnancy. So things like pulmonary edema due to preeclampsia or ARDS from an infection source, or what are the ones that are increased with pregnancy? So the risk of venous thromboembolism is increased. There's gastric acid aspiration from the GE junction being more changing the angle of the GE junction. There may be transfusion-related acute lung injury. Patients there's about a third of patients whose asthma might get worse, and such. And then there are non-specific conditions that are not related. That could be anything from trauma or drugs or toxins or, for instance, pancreatitis that some patients may be more prone to. So again, what's unique to pregnancy, what is exacerbated by pregnancy, and what is unrelated to pregnancy. So this also includes things like bacterial pneumonia and such. So let's now take some of these disease states. I want to make sure I'm on time. Okay, so I should be able to finish this part in about 10-15 minutes and leave about 15 minutes for questions. So acute respiratory distress syndrome in pregnancy, the things that can cause this is commonly are things like amniotic fluid embolism. So pregnant patients are at increased risk for ARDS compared to patients who are non-pregnant due to the increased circulating blood volume. There's also a decrease in serum albumin level, and there's an upregulation of components of the acute inflammatory response. So in this situation, ARDS may be caused by conditions unique to pregnancy. So if there is amniotic fluid embolism, conditions augmented by pregnancy such as aspiration pneumonia, as I said, or conditions unrelated. So although ARDS is relatively rare, there's about 60% per 100,000 live births in roughly throughout the world. It is become more common recently related to COVID-19 during the pandemic. The aspiration pneumonitis is a significant risk during labor and delivery due to the increase in the intra-abdominal pressure, the increased tone of the lower esophageal sphincter, and the use of the supine position for delivery. Pregnant women are also more susceptible to respiratory complications of viral pneumonitis, especially as you may remember COVID-19, influenza, and then the amniotic fluid embolism is uncommon, but when it does occur, it is a devastating pregnancy-specific condition that occurs in about 7% to 8% of 100,000 pregnancies. There's a very high mortality rate, accounting for about 14% of all maternal deaths. I tried to find in the African subcontinent what the rates were, but it seems like it's very difficult to get all that data. It was so I had to get the data that was more worldwide. So I apologize. The data is not available. There are some small studies, and they still say that there's a lot of bias in those studies. So transfusion-related acute lung injury, these manifest kind of as a sudden dyspnea during or within 6 hours of transfusion of anything that is plasma-containing blood products. So moving on to cardiogenic pulmonary edema, this is an area that we need to pay attention. So pulmonary edema, patients who, there's about 3% of patients with preeclampsia can develop a pulmonary edema. The preeclampsia itself varies. The hemodynamic profile can change. So if you had hemodynamic measurements, you see that in some patients there is a hypodynamic type. with increased systemic vascular resistance, which is usually in the early preeclampsia stage. And then there's a hyperdynamic subtype, which is usually in the late preeclampsia stage. So the patients who do develop pulmonary edema, this commonly presents immediately postpartum because of the increased central circulating volume. That's related to either fluid administration as well as the return of blood from the contracting uterus. And also there's low colloid oncotic pressure and abnormal vascular permeability that is likely contributing to this. So going over to pulmonary infection. So pregnancy is associated with a downregulation of the cell-mediated immunity with intact upregulation of the humoral immunity. So this is because nature has it that it's allowing the tolerance of the paternal antigens of the fetus so that it's not attacking the fetus. So because of this, the changes of the immune system now increases the pregnant person's susceptibility to certain infections. So as we saw during the pandemic, COVID-19 infection appeared to be much more severe during pregnancy. Those patients had increased hospitalization, intensive care unit admissions, as well as complications of preterm birth. The patients, similarly, influenza acted the same way, and every year we see that happening. Right now, we have a significant amount of patients who are admitted either with influenza or COVID-19 in the hospital. Incidence of the community-acquired pneumonia, it is pretty similar to the general population of respiratory failure, but the problem with the pregnant patients is it may lead to either precipitate preterm labor, or the babies may be small for gestational age, or there may be intrauterine or neonatal death. So a delayed diagnosis frequently happens in this case because of there's kind of an inappropriate concern for radiation exposure, limiting chest imaging. The incidence of community-acquired pneumonia is very similar to the general population, as I said. The other conditions that you need to be aware of is asthma. So, there is a saying that it's a third, and a third, which is about a third of patients with asthma. There's no change. There's about a third of those patients who actually the asthma is better controlled, and then there is a third of patients whose asthma changes to the worst. So there are hormonal changes of pregnancy that affects the asthma in a variable way. But as I said, about a third of asthmatics, it deteriorates during their pregnancy. So the drugs that are used for labor, also some of these can cause bronchospasm. The oxytocin carries very little risk, but the prostaglandins or the ergovines that we give to reduce the postpartum bleeding can lead to bronchospasm. So we have to be wary of that and be on the outlook when in the event that a patient is already having uncontrolled asthma when we have to give any of these medications. So the risk of moving on is the risk of thromboembolic disease, so pulmonary emboli, DVT, is significantly increased in pregnancy, and it leads to cause of maternal mortality about 10% of pregnancy-related deaths worldwide. So this is where I was also trying to look for the African subcontinent, and it said that most of the data were from very small studies from the 1900s, but in the late 1900s, but what they saw was that there was a significant amount of bias. So the peak incidence in the happens in around the postpartum period. So if you have a patient that just delivered and is in respiratory distress, you should think about DVT or PE, particularly after a cesarean section. The diagnosis can be made by either getting duplex ultrasounds or ventilation perfusion scanning. I'm not sure how readily those are available to you, but a CT scan with contrast angiography can be safely performed during pregnancy. The VQ scan usually gives a good quality scans because there's usually these patients do not have pulmonary parenchymal abnormalities, so they don't have any abnormalities like pleural effusions or infiltrates that makes the VQ scan reading difficult. But the CT angiography, the risk of maternal breast tissue exposure that exposes to the doses of radiation, and then there's concern of risk of breast cancer. So, a single dose in a life-threatening situation, you have to think about the risks versus benefits that you need to take into account. The ventilation management, so there are different ways of management, the airway management, the non-invasive ventilation, and invasive mechanical ventilation. So we have to remember that the obstetric airway, as I said, is considered a difficult airway managed by an operator with appropriate skill. Failed intubation happens about 8 times more commonly than in other anesthetic intubations because of the airway edema. In the pregnant patient, the use of non-invasive ventilation increases the risk of aspiration, but it is clearly beneficial in some situations. So particularly in the obstetric respiratory complications, which are quickly reversible. So if somebody is awake and alert and there's no obvious contraindications, and they're in pulmonary edema, and you can get that patient diuresed, by all means, use the non-invasive ventilation to avoid invasive mechanical ventilation. So I'm going to show you some non-conventional support that has been approved that we have used. So inhaled nitric oxide, it has been used with no teratogenicity or so there's obviously no randomized trials that it's going to be done, but it has been used in die emergencies to save the mother. That has not led to any adverse effects on the fetus. The extracorporeal life support, ECMO, has been used, and there's data that has come from H1N1 as well as COVID-19 that was used during the pandemic and prior to that during H1N1. So I have these pictures here of prone positioning. I'm going to put it in your chat. An article I think will be helpful. There has been algorithms and the process of proning patients, because we know that proning has been helpful for most of our patients, and especially when the P2F ratio is less than 150. So we should allow that, and we have ourselves at Cooper prone pregnant patients appropriately. So you kind of follow these guidelines where you actually you allow the gravid abdomen to fall between the two pillows, or foam that you can do, and then you have these different areas that you keep the pressure from occurring. So mechanical ventilation during pregnancy, so looking at the comparison with the non-pregnant patient. So you're going to follow guidelines. So height volumes, you're still going to give 6 ml per kg ideal body weight. So remember, because the mother is not going to be at their ideal body weight, so you go by their height. The plateau pressure limit, less than 30. Higher pressures are often accepted, but suggest that there's no difference compared to the non-pregnant population when you do prospective data. Usually, the oxygen saturation goal is between 88 and 92 in a non-pregnant patient. There's no data to say that we have to keep the oxygen saturation above 94, but it is unclear if this is necessary. But the important thing is that we avoid hyperoxia so that we don't, which cause to avoid any untoward effects if there is any vasoconstriction. Arterial carbon dioxide, permissive hypercapnia. We usually allow the PCO2 sometimes to rise above 100 in these situations, but we avoid hypocapnia and alkalosis because we know that that the pregnancy normal is about 28 to 32. Hypercapnia at moderate levels, about 50 or so, may be safe, but there's no way to have a randomized trial in this situation. Patient positioning, we usually position these patients in semi-upright position. On the pregnant patients, because of the IVC, you want to put the patient in left lateral decubitus position for hemodynamics and for adequate blood flow back to the circulation. Head elevation is important to reduce reflux. Prone positioning, as I said, good data benefiting ARDS. It's technically difficult in a pregnant patient, and but it's feasible, and there is no evidence that it's going to cause harm. So the outcome of mechanical ventilation during pregnancy, these are about my last two slides. Pre-COVID database, we found that maternal mortality of about 9% for pregnant women, mechanical ventilator for ARDS. There's a neonatal mortality from 3 to about 30%, so big range. There's a retrospective study of like 71 women who were more than 25 weeks, showed that about 20% of babies required mechanical ventilation post birth, soon after birth, and about 20% of them had growth restriction, and about 14% had neurologic impairment at 6 months. So the points that I want to make is, do not alter the usual care due to the presence of pregnancy unless there's very good reason to do so. So you're going to take care of the mom the best you can. And of course, you want to try to save the baby, but if there's no mom, there won't be a baby. So you want to make sure that you don't alter the usual care that has proven to be beneficial. The outcomes, through excellent communication. So with the multidisciplinary team, so that should include the critical care physicians, nurses, respiratory therapists, and obstetrics, maternal fetal medicine, anesthesia, and obstetric medicine. So with that, I want to say our goal is to have a healthy mom and a healthy baby, but we want to priority is mom until we can, and then hopefully we can also have a healthy baby at that point.
All right. Thank you so
These
much,
are
Dr.
some references. Yes, I'm so sorry about the early confusion. So hopefully we were able to get that taken care of.
Yeah, I think it was okay. Yeah, thank you. So I would encourage anyone who has any questions, you could unmute yourself, you can ask, or you could put it in the chat. But if I could begin, I'm interested to know how would your point of care ultrasound focus change during for a patient for someone who is pregnant? Like any considerations that you should keep in mind?
Certainly, we will look at the, the fluid status if a patient is, looking at the IVC, looking at the right ventricle, if you're concerned about pulmonary emboli, before we rush the patient down to, a CT scan, or when there's CT scans and VQ scans not readily available. You can use your ultrasound that is readily available to take a look at the right ventricle to see if there's any indication that the patient has, if the patient has any evidence of an acute pulmonary embolism. Certainly, you can look at the lungs itself to look at to see if there's pleural effusions that may indicate potentially that the patient is whether it is post cardiomyopathy related, or looking at the heart, and then pneumonias if there's localized areas of consolidation by way of B lines that you can assess. So definitely yes, the POCUS is extremely helpful. And should be one of those things that you would continue to use, whether the patient is pregnant or not.
Okay, thanks. Dr. Moise, you have a question? Please go ahead.
Hi, it was a good presentation.
Hello.
I really enjoyed it. My question would be, the problem comes about with ARDS and pregnant ladies. Which ventilator maneuvers would you use apart from the prone positioning and so forth? Like, would you prefer a volume control mode and increase the PEEP, or would you tackle with a pressure control mode and increase the PIP pressures and find a very good in between opening and closing pressure so that you can recruit the lungs? Which maneuver would you prefer on a pregnant patient?
So it is whatever is most comfortable for the patient, because in these patients, and I didn't, for the sake of time, I didn't add a slide about medication, but, if we have to sedate a patient, if we have to paralyze a patient, we may need to do that. But if we can find the most comfortable mode of ventilation and the best synchrony, that the patients are synchronous, perhaps we won't need to use, a neuromuscular blockade that potentially could be, over time harmful for the fetus, especially if it's used long term. So there's no particular mode of ventilation. So it's no, as I said in that last slide, don't change anything you normally do. Do exactly what it is that you would normally do for the pregnant patient, whether you do the same for the non-pregnant patient. The only thing that's going to be different is that you may tolerate a higher plateau pressure because of the intra-abdominal, the chest wall compliance itself, because you're not going to be able to judge that unless you have a esophageal balloon to be able to say exactly what that pressure would be. But as far as maneuvers, oxygenation, you wouldn't do anything different than, increasing your PEEP based on the PEEP table, going through the lung protective strategy and such.